Good afternoon. Thank you, Mo, and thank you very much to the organisers of the meeting for inviting me to speak at this session. I've got no conflicts of interests to declare. I think today's lunchbox session is, as Sir Dave Brailsford would have described his advances for the cycling team for the Olympics, is in marginal gains. But I think that's why it's important, because we are now in the era where 1% gains in improvement in our patients can and will steadily make a difference to their outcome. Fortunately, gross air embolism into the circulation during cardiac surgery is now relatively rare. But before the mid-1980s, it was reported to occur in as frequent as 1 in 2,500 cardiac cases. Last year, in a large US national survey, the incidence of gross air embolism was reported as 1 in 30,000 cardiac cases. But we would be wrong to consider air entrained into the circulation as a merely historical event. There are numerous interventions by perfusionists, surgeons, and even ourselves as anaesthetists that risk and indeed do introduce air into the circulation or other gases. 3 notable examples is our often failure to completely de-air the venous line. We continue to use cardiotomy suction, and in the vast majority of bypass with a reservoir, we have a continuing blood-air interface. This is a readout from the GAMT bubble counter, which shows in the blue the smaller number but larger bubbles detected in the venous line. And despite the introduction of arterial line filters of increasingly small bore, a large number, albeit of smaller microbubbles, are detected in the arterial line before it enters the patient. In fact, you probably can't see the figure in red, but during this simple case of coronary artery bypass grafting, over 20,000 GME were detected in the arterial line. And this agrees with published data using, albeit a different bubble counter, with about that number with CABG, but up to 4 times that number in open heart surgery, as you can see here. So when do GME enter the circulation? Well, we anticipate them at the beginning of bypass because air, despite attempts to de-air the circuit, will be on the surfaces of the tubing. And again, we could expect it when the cross clamp is removed, but you can see that there is a very large peak that is cumulative during the rest of the bypass run. In fact, on top of what I've just said, in recent years, in our attempts to minimize the size of the bypass circuit, we've even introduced things that further risk the entrainment of air, vacuum-assisted venous drainage, and with mini bypass, we use kinetic-assisted venous drainage. So not only does vacuum assist increase the risk of entraining air, if we compare naught, which is gravity, and minus 40 millimeters of mercury, you can see that the bubble counts detected on transcranial Doppler were rather similar and low. But if the negative pressure is increased beyond minus 40, in this case minus 65 millimeters of mercury, there is a considerably larger number of bubbles detected by transcranial Doppler. And this isn't necessarily because of air entrainment, but because we seem to alter the air handling capacity of the bypass circuit. This is our graph about looking at the venous line pressures with mini bypass. You can see that the median pressure with mini bypass approaches or is at about minus 50 millimeters of mercury. but the peak negative pressures detected in the venous line approach 200 or minus 200 millimeters of mercury. And Aboud and his colleagues not only agreed with our figures, but their statistic was that 20% of negative pressures in the venous line exceed minus 150 millimeters of mercury. So is this simply a problem of poor surgical technique, easily overcome by double purse string suturing and eliminating entrainment of air? I'm suggesting that what you're going to see in the bottle, which has been sharply accelerated downwards with a negative pressure applied to the bottle, is that with negative pressure we risk what's called gaseous cavitation. This is a transient hydrodynamic phenomenon where, in the presence of a large negative pressure and sudden flow acceleration, bubbles nucleate, grow, and then collapse, all in a fraction of a millisecond. But the subsequent vortex, which you may have spotted just when those bubbles collapse, produce a considerably larger number, albeit of smaller, but more persistent bubbles. This is also what occurs each time a mechanical heart valve closes, that at the point of maximal acceleration, gaseous cavitation causes the generation of bubbles, and the subsequent vortex generates further microbubbles, and these can be detected by transcranial Doppler with a frequency of 0.2 to up to 5 hits per minute, every minute that a patient has a mechanical heart valve opening and closing in their heart. It's also what we see with patients on long-term dialysis, cavitation of bubbles in the dialysis circuit, and people have said that this is why patients on long-term dialysis have pulmonary hypertension and perhaps explains cerebral atrophy in these patients. The other generation of gas bubbles in the circuit are due to cooling and rewarming. We often think about these occurring in the heat exchanger during rewarming. As the solubility of gas decreases, it comes out of solution, some of it passes the arterial line filter and enters the patient. But conversely, you may not have thought about this, as cold blood on cooling enters the warmer patient, we may be delivering large bubbles into the patient at the aortic cannula tip. So does any of this matter? It matters depending on the size of the microbubble, and I will be looking at that in a little minute. It depends, based on the size of the bubble, how long it takes for the dissolution of that bubble to occur. And you can see if you have a 10 micron bubble, it can just take 6 seconds in the circulation to disappear. But if you have an 100 micron bubble, it can take up to 10 minutes to disappear. And finally, we're beginning to understand that the susceptibility of the underlying brain, especially the elderly brain, perhaps the hypertensive, the alcoholic, and those with COPD, appear to have brains more susceptible, perhaps because of a higher inflammatory basis to their elderly brain, are more susceptible to these type of injuries. So what size are the bubbles? Well, the red graph is the one to look at, and you can see that the median size is about 40 to 50 microns, and that would fit in with a 25 to 40 micron arterial line filter. This is broken down into smaller aliquots, so in fact the peak of the size of the bubbles is closer to 25 to 35 microns. Very small, perhaps they're not of any significance, until you remember that the capillaries are 5 to 14 microns. So the majority of these bubbles will, as they pass through capillaries, interact with the endothelium. Large bubbles will have an occlusive effect with downstream ischemia. That's fairly understandable. but 50 to 200 micron bubbles, as they interact with the endothelium, will cause an increase in large pore radii and an inflammatory response with an increase in interstitial fluid. This has been most consistently studied in models of the cerebral circulation, where upstream from the bubble there is an increase in attempted increase in cerebral blood flow, but in fact there is a progressive fall in cerebral blood flow to about 50% of the previous values, and this can persist up to 60 minutes even after the bubble has transited. Together with that, animal models have measured a marked fall in cortical pH and a decrease in cortical somatosensory responses. And this persists for several hours after the gas bubble insult. Even small bubbles can cause functional stripping of the endothelial cells, an increase in these large pore radii. It doesn't appear to occur in neutropenic animals, so this response is thought to be mediated by leukocytes rather than purely mechanical. But as those neutrophils aggregate around the bubble, they produce local tissue destructive mediators. On top of that, platelets rapidly aggregate around the microbubble, and other mediators generate the perfect storm for micro-thrombus formation as a bubble slowly transits capillaries. I'm very grateful to Dr. Chris de Boer and Nick Koning from the VUMC in Amsterdam, who gave me the next couple of slides. They use side stream dark field imaging to look at the microcirculation under the tongue. And what they show, this is a baseline of the microcirculation, but within 10 minutes of going on bypass, there is a marked decrease in perfused capillary density. This is even worse by the time you finish bypass and 1 hour later, and they report that it isn't back to normal until about 72 hours after bypass. Now, what side stream dark field imaging can't do is see if there are any GME or microbubbles passing through those capillaries exactly preceding the response that they've seen. And I saw Chris de Boer present this last year, and so I communicated with them and I said, do you think it is possible that this is due to GME in your human population? Because we know that whatever they do, they won't be able to eliminate GME. And it is certainly tempting to speculate that the thing they are not seeing is GME that largely explains what they are seeing. So graphically, 10 minutes after going on bypass, there is a significant decrease in perfused capillary density and also a significant increase in the number of stopped capillaries. And it is far, far out of proportion to that which results from hemodilution alone. Now, over 20 years, and one of these papers is from 20 years ago and one is from 1 year ago, cardiac surgeons and anaesthetist perfusionists have attempted to correlate the incidence of GME with neurocognitive outcomes. And there are two things really to say before we're too critical of this literature, is that the methods available to detect GME have constantly changed and certainly were not very sophisticated 20 years ago. Secondly, the timing of neurocognitive testing is very varied, and if you test at 1 day, we all know that patient who fails to wake up appropriately, that is not fit to extubate until the next morning, and then over the next day or two they appear to come okay and everything seems fine. But neurocognitive testing is often done at 3 weeks and is often repeated at 3 months. And perhaps it should be no surprise that we are unable to detect any difference from those who we think had a high incidence of GME from those who we think were relatively spared. But these are a couple of papers that have either looked at percentage decrease from baseline, or the percentage of patients with a deficit showing a very neat correlation with exposure to GME. So what do the patients get? Well, they get what I just said, that patient who fails to wake appropriately, who isn't fit for extubation. Categorized a little bit better as a cerebral type 2 injury with the pathology as listed here. But what that goes on to be correlated with is an increase in hospital mortality, a doubling of hospital length of stay, and a 4 times incidence of patients who are not fit to be discharged directly home. So the old adage, if you don't take the temperature, you won't find the pyrexia, is absolutely true when it comes to GME detection. We can pretend it doesn't happen, or we can employ one of these 2 main commercially available devices to keep a track on the GME exposure that we think we're giving to our patients on a daily basis, the GAMT BC200 or the emboli detection and quantification device on the right. These use pulse wave ultrasound and report to be able to detect up to 1,000 bubbles per second, of the range 5 to 10 up to 500 microns. But Philip de Sommer wrote a very pertinent article which reminds us that large numbers of small bubbles are seen by the monitors as a smaller number of large bubbles because of the resolution of the ultrasound. And secondly, he warns us against comparing one device with another. Beyond the bypass circuit, and you're going to hear a little bit more about transcranial Doppler later, but transcranial Doppler has become ever more sophisticated. It now reports to be able to differentiate solid from gaseous micro-emboli, and the science behind that is if you insonate with 2 frequencies, then solid micro-emboli reflect more ultrasound at a higher frequency, and gaseous micro-emboli reflect more ultrasound at a lower frequency. And it's readily applicable using a headset to all of our patients having cardiac surgery. So, lessons about how we can limit the clinical sequelae from patients' exposure to GME is first of all to be aware of them, to not pretend they don't exist. We need to recognize that perfusion interventions, surgical interventions, and anesthetic interventions all risk the introduction of GME. And my belief is that better detection technologies, as they become more widespread, will lead us to develop better preventative and treatment strategies. The sound isn't... Could you just turn the sound up? It's a shame because our chief perfusionist... You just got that. There's nothing that sits you up quite as sharply as when you hear sounds like that when you do something to the patient and you realize that that is thousands of GME being delivered at least into the venous line, but rapidly being transmitted, as you saw the red curve grow, into the arterial line. 2 slides on what we can do about it if our patients get a lot of air or gas into their circulation. We mustn't forget hyperbaric oxygen therapy, but of course this is really used when you suspect the patient has had a gross air embolism, and the lesson here, having reviewed these few papers in cardiac surgery, is the sooner you get them to the DRC, the better. 4 to 12 hours, otherwise they're going to have a poor outcome. I don't think it's applicable, but if you could put a patient who had had a large exposure to GME into an HBO chamber, then we can rapidly denitrogenate the brain of the microbubbles, but really it's not practical. From the diving literature, heparin and platelet inhibition has been used to see if it changes the outcome of animals that are dived and given the bends. And there is some evidence that aspirin, clopidogrel, but perhaps not heparin, alters that micro-thrombus formation and hence the deleterious effect of microbubbles. Lignocaine is slowly coming into our literature as a cerebral protective mechanism. It decreases cerebral pressures and may decrease cerebral edema, but it hasn't been specifically correlated to the incidence of GME. And I think as we get better technologies that can detect GME, we will see whether lignocaine has a part to play. It should stabilize the endothelium. Similarly, in animal models, surfactants that should increase the rate of dissolution and decrease the adherence with the endothelium, decreasing the interaction between the bubble and the endothelium, have shown some promising results, but there is no human data on that. And I put up there that a decade ago, there was the beginning of literature to show the benefits of perfluorocarbons. Really promising because, of course, they can absorb carbon dioxide, nitrogen, and oxygen. They're very small particles mopped up by the reticuloendothelial system, and they should and could mop up GME very rapidly. The drug that you can't see on this screen is xenon. Again, promising as a neuroprotective agent by its interaction as an NMDA antagonist, but it's been shown by Professor Grocott's group and Burkett Mackinson to increase the size of GME in a rat model by 20%, and Burkhart's group showed that that significantly increases the cerebral injury associated with microbubbles. So there's the summary. We need to detect them better. We need to think of a way of preventing the deleterious effects, and we need to continue to work on mechanisms to eliminate GME from the circulation. Thank you very much.